In this lecture, we present the antibiotic that inhibit the protein synthesis. And as we used to present the general uh, uh, pictures of the all the antibiotics in the that inhibit the protein synthesis, and be classified according to the site of action, according to the type of ribosomal inhibition, either to the 30S ribosome or 50S ribosome. And in general, we will focus on five antibiotics: the aminoglycoside, linezolid, tigecycline, macrolide, and the clindamycin. All these antibiotics act by inhibition of the protein synthesis. And starting by aminoglycoside, the aminoglycoside like amikacin, gentamicin, and topramycin, they are mainly used for covering the gram-negative bacteria, and Pseudomonas have no coverage of the anaerobes and atypical. The gentamicin may cover some of the MRSA, but it's not all the MRSA. The aminoglycoside is concentration dependent, and so it is better to be given as a once daily dose. The dose of the aminoglycoside for amikacin is 15 to 20 milligram once daily dose. For gentamicin and topramycin, it's 5 to 7 milligram per kilogram once daily dose. And the dose is adjusted according to the body weight. So that if the patient have a body mass index less than 30, use the actual body weight. But if the patient have BMI more than 30, use what's called adjusted body weight. The adjusted body weight is the ideal body weight plus 0.4 multiplied by the actual body weight minus the ideal. For intrathecal or intraventricular injection, the amikacin used as a 30 milligram per day, and for gentamicin 4 to 8 milligram per day. In infective endocarditis, the gentamicin is used in split dose 1 milligram per kilogram every 8 hours. The main side effect is the ototoxicity, deafness, and vertigo, and reversible acute tubular necrosis. For linezolid, it is mainly against gram-positive, especially MRSA and Enterococcus, and they have some coverage against Clostridium. The dose is 600 milligram every 12 hours. There is no dose adjustment either in obese patients or in renal patients. Used mainly in pneumonia, skin and soft tissue infection, and also it inhibits the toxin production in toxic shock syndrome. The main side effect is the bone marrow, but it occurs after long-term exposure, mainly after every 2 weeks, in the term of the thrombocytopenia, anemia, and neutropenia. And this bone marrow depression increase the incidence with renal impairment. This means that patient with renal impairment, it increased the risk of bone marrow depression. It also have some monoamine oxidase inhibitors. So there is some increase the risk of serotonin syndrome in the term of fever, hypertension, and agitation, with concomitant administration of the serotonin selective reuptake inhibitors. It has some neurotoxicity after long-term exposures in the form of the peripheral neuropathy and optic neuropathy. And unfortunately, the neurotoxicity of the linezolid is irreversible. For tigecycline, there's a broad spectrum antibiotics covering gram-positive MRSA, gram-negative pseudo anaerobes and atypical, but has no coverage over the Proteus and Pseudomonas. The usual dose is loading with 100 milligram loading followed by 50 milligram every 12 hours. But we double this dose, especially in patients with hospital-acquired pneumonia or patient infected with multi-drug resistant pathogens. And we reduce this dose in patients with child C cirrhosis. It's used mainly for skin and soft tissue infection, complicated abdominal infection, and community-acquired pneumonia, but it is not recommended in bloodstream infection and urinary tract infection. The side effect mainly is nausea and vomiting, elevated liver function. For macrolide, it covers the stripped methicillin-sensitive staph aureus, but have no coverage of the MRSA, and it used mainly to cover the atypical microorganism. So the dose for azithromycin is 500 milligram per day for 3 to 5 days, and for clarithromycin, 500 milligram every 12 hours for 7 days. Used mainly for community-acquired pneumonia. The main side effect is the prolonged QT interval, and this may increase the risk of the ventricular arrhythmia and cardiac death. The drug interaction main with clarithromycin with a statin, it increase the risk of rhabdomyolysis, and also with the calcium channel blocker that it increase the risk of hypotension. For clindamycin, it is covered the gram-positive and anaerobes, but it cover MRSA also, but not for cover community acquired MRSA, but not covering nosocomial MRSA. This means that if the patient have a suspicious of nosocomial MRSA, the clindamycin cannot be used in this state. And it also have some resistance to the anaerobe to the clindamycin, so it is not the preferred agent for covering intra-abdominal infection. The doses is actually 150 to 450 milligram every 6 hours. But in toxic shock syndrome, we may increase the dose to 900 milligram every 6 hours. It's used for some sort of community-acquired MRSA or anaerobic infection in the head, neck, and lung. The main side effect is pseudomembranous enterocolitis as it increase the risk of Clostridium difficile colitis. Thank you.